Hey everyone, Chris here from MedPrepToGo, and I wanted to let you know about our premium Step 1 bundle podcast, which gets you all of Crush Step 1 and our Step 1 question podcast combined and ad-free. You'll also get early access to new content as it becomes available. Upgrade your studying now and learn more at MedPrepToGo.com. Hey everyone, Chris here from MedPrepToGo, and I wanted to let you know about our premium Step 2 bundle podcast, which gets you all of the Step 2 secrets and our Step 2 questions podcast combined and ad-free. You'll also get early access to all of our Step 2 questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at MedPrepToGo.com. Hey everyone, Chris here from MedPrepToGo, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrepToGo on Facebook, Instagram, LinkedIn, and now YouTube. We'd greatly appreciate it as we try to spread the word about MedPrepToGo and keep medical education accessible and affordable. Hey everyone, Chris here from MedPrepToGo, and welcome to another episode of our USMLE Step 1 Questions podcast. In this episode, I'll be reading 3 more anatomy questions from our online Qbank, and as always, you can read these questions and more at MedPrepToGo.com. And now, let's get started with question 1, Anatomy 20. A 46-year-old man comes to the clinic because of 2 weeks of lower back pain radiating down to his right leg. The pain began after he lifted a heavy box while moving furniture. He has no fever, weight loss, bowel or bladder dysfunction, or history of cancer. Neurologic examination shows decreased sensation over the lateral leg and dorsum of the foot. Strength is mildly decreased with dorsiflexion of the right great toe. Patellar reflexes are 2+ bilaterally, and Achilles reflexes are also 2+ bilaterally. Which of the following spinal nerve roots is most likely affected? Is it A, L3, B, L4, C, L5, D, S1, or E, S2? And the correct answer is C, L5. This patient has sensory loss over the lateral leg and dorsum of the foot with weakness of great toe dorsiflexion. L5 radiculopathy commonly results from posterolateral herniation of the L4-L5 intervertebral disc, which compresses the traversing L5 nerve root. The L5 dermatome includes the lateral leg and dorsum of the foot, and L5 motor involvement can impair dorsiflexion of the great toe through the extensor hallucis longus. Normal patellar and Achilles reflexes are also consistent with L5 radiculopathy because those reflexes primarily assess L4 and S1, respectively. Answer choice A, L3 is incorrect. L3 radiculopathy typically causes pain or sensory loss over the anterior thigh and may cause weakness of hip flexion or knee extension. It would not be expected to cause sensory loss over the dorsum of the foot or weakness of great toe dorsiflexion. Answer choice B, L4 is incorrect. L4 radiculopathy often causes sensory loss over the medial leg and may reduce the patellar reflex. Although L4 contributes to ankle dorsiflexion, isolated weakness of great toe dorsiflexion with sensory loss over the dorsum of the foot is more characteristic of L5 involvement. Answer choice D, S1 is incorrect. S1 radiculopathy typically causes sensory loss over the lateral foot and posterior calf, weakness of plantar flexation, and decreased Achilles reflex. This patient's Achilles reflex is normal and his weakness involves great toe dorsiflexion rather than plantar flexion. Answer choice E, S2 is incorrect. S2 contributes to sensation of the posterior thigh and upper posterior leg and participates in sacral plexus function. An S2 lesion would not produce the classic pattern of dorsum of foot sensory loss and great toe dorsiflexion weakness seen in this patient. Key learning point. L5 radiculopathy causes sensory loss over the lateral leg and dorsum of the foot and may cause weakness of great toe dorsiflexion, while the patellar reflex primarily tests L4 and the Achilles reflex primarily tests S1. Question 2, Anatomy 21. A 28-year-old man is brought to the emergency department after falling asleep with his right arm draped over the back of a chair after drinking alcohol. When he woke, he was unable to extend his right wrist. He has no neck pain. Past medical history is negative. Physical examination shows weakness of wrist extension, finger extension, and thumb extension. Sensation is decreased over the right dorsal first web space. Tricep strength and reflex are normal. Sensation over the middle finger is intact. Which of the following structures is most likely injured? Is it A, C7 nerve root, B, median nerve, C, musculocutaneous nerve, D, radial nerve, or E, ulnar nerve? And the correct answer is D, radial nerve. This patient has compressive radial neuropathy, often called Saturday night palsy, due to prolonged compression of the radial nerve in the spiral groove. The radial nerve innervates the wrist extensors, finger extensors, and thumb extensors. Injury can cause wrist drop. Sensory loss over the dorsal first web space is a classic finding because the region is supplied by the superficial radial nerve. Normal tricep strength and reflex suggest that the lesion is distal to the radial nerve branches to the tricep, which typically arise proximal to or within the axilla. Answer choice A, C7 nerve root, is incorrect. C7 radiculopathy can cause weakness of elbow extension, wrist flexion, finger extension, or finger flexion, and sensory symptoms often involve the middle finger. This patient has preserved tricep strength and reflex and intact sensation over the middle finger, making C7 radiculopathy less likely than a radial nerve lesion. Answer choice B, median nerve, is incorrect. Median nerve injury can impair thumb opposition, wrist flexion, forearm pronation, and sensation over the palmar lateral 3.5 digits. It does not cause isolated wrist drop or sensory loss limited to the dorsal first web space. Answer choice C, musculocutaneous nerve, is incorrect. The musculocutaneous nerve innervates the biceps brachii, brachialis, and coracobrachialis and provides sensation to the lateral forearm through the lateral antebrachial cutaneous nerve. Injury would cause weakness of elbow flexion and forearm supination, not wrist and finger extension weakness. Answer choice E, ulnar nerve, is incorrect. Ulnar nerve injury causes weakness of interossei, medial lumbricals, adductor pollicis, and hypothenar muscles with sensory loss over the medial hand and medial 1.5 digits. It does not explain wrist drop or decreased sensation over the dorsal first web space. Key learning point. Radial nerve compression in the spiral groove causes wrist and finger extension weakness with sensory loss over the dorsal first web space, while triceps function is typically preserved. Question 3, Anatomy 22. A 45-year-old man comes to the clinic because of difficulty turning his head to the left and raising his right shoulder after excision of a lymph node from the right posterior triangle of the neck 1 week ago. He has no difficulty swallowing, speaking, tasting food, or moving his face. Physical examination shows weakness with right shoulder shrug and weakness turning the head to the left against resistance. Sensation over the neck, shoulder, and upper extremity is intact. Pupillary size and sweating are normal bilaterally. The damaged nerve fibers most directly responsible for this patient's weakness normally innervate which of the following target tissues? Is it A, cardiac muscle, B, glands, C, skeletal muscle, D, smooth muscle, or E, taste receptors? And the correct answer is C, skeletal muscle. This patient has injury to the right spinal accessory nerve during a posterior triangle lymph node excision. The spinal accessory nerve innervates the sternocleidomastoid and trapezius muscles, causing weakness with contralateral head rotation and ipsilateral shoulder shrug when injured. These muscles are skeletal muscles under voluntary motor control, so the injured fibers are somatic efferent fibers. The intact sensation, normal facial movement, preserved taste, and absence of autonomic findings help distinguish this lesion from sensory, bronchial motor, special sensory, or autonomic pathway injury. Answer choice A, cardiac muscle, is incorrect. Cardiac muscle is regulated by autonomic visceral efferent fibers, including sympathetic fibers that increase heart rate and contractility, and parasympathetic vagal fibers that decrease heart rate. Injury to the spinal accessory nerve does not directly affect cardiac muscle. Answer choice B, glands, is incorrect. Secretomotor innervation to glands is mediated by autonomic fibers, such as parasympathetic fibers to the lacrimal, salivary, and nasal mucosal glands, or sympathetic fibers to sweat glands. This patient has a voluntary motor deficit involving the trapezius and sternocleidomastoid rather than impaired lacrimation, salivation, or sweating. Answer choice D, smooth muscle, is incorrect. Smooth muscle is innervated by autonomic visceral efferent fibers and is found in structures such as blood vessels, bronchi, gastrointestinal tract, bladder, and iris. A lesion affecting smooth muscle innervation would cause autonomic findings such as altered pupillary size, vascular tone, or visceral motility, rather than isolated shoulder shrug and head turning weakness. Answer choice E, taste receptors, is incorrect. Taste is carried by special visceral efferent fibers from cranial nerves 7, 9, and 10. Injury to these fibers would cause gustatory deficits, not weakness, of the sternocleidomastoid and trapezius muscles. Key learning point. Somatic efferent fibers innervate skeletal muscle, whereas visceral efferent fibers provide autonomic motor innervation to cardiac muscle, smooth muscle, and glands. And that will conclude this episode of our USMLE Step 1 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrepToGo on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 1 questions at MedPrepToGo.com. Happy studying! Hey everyone, Chris here from MedPrepToGo, and I want to take a quick break to announce that our first course is now live. Comprehensive Endocrinology is a video series with Dr. Raj Dasgupta that features 9 hours of content in 8 modules. This course is useful for learning endocrinology for internal medicine, family medicine, USMLE Step 3, and COMLEX Level 3. And this content is exclusive to the video series and won't be available on any of our podcasts. Keeping with our philosophy of making medical education affordable and accessible, this course is available for just $10 a month or $20 for a year. So check it out now and start learning at MedPrepToGo.com. And stay tuned for more courses coming later this year.